So we know the heart failure with the reduced ejection fraction is the vast majority, 2/3 of the heart failure patients in India. This is the data from the Trivandrum Heart Failure Registry, the Kerala Registry, and the National Heart Failure Registry supported by ICMR. We can see that the preserved ejection fraction is only around 12 to 16%, and the rest of it is contributed by the mid-range ejection fraction. Coming to the medical management, we know there is a significant, when we in the 80s we had only diuretics, then subsequently we had the other 3 drugs coming into, and from 2014 onward there are many trials and many new molecules coming up. Now we have an array of drugs and devices which have shown significant benefit in heart failure. So before 2014 we had the 3 basic drugs, ACE inhibitor or ARB, beta blockers and mineralocorticoid receptor antagonists. That itself, so this is the data from the 3 major registries, the first 3 columns, and that shows that the utilization of the 3 drugs is in the tune of around 25 to 47% only. And that itself, even if though it was utilized in such a small percentage of patients, you can see that this is the data from the National Heart Failure Registry which we coordinated. You can see that there is a significant benefit in patients with the reduced ejection fraction. You can also see that there was benefit in patients with the mid-range ejection fraction also. Then came the major trials like DAPA-HF and EMBER-REDUCE, which showed a 25 to 26% benefit with the dapagliflozin and empagliflozin. And this was in the primary endpoint, hard endpoints, cardiovascular death or heart failure hospitalization. And you can see that the benefit was seen in patients with or without diabetes, and those patients even with chronic kidney disease. So thus came the 4 pillars of heart failure therapy: beta blockers, ACE, ARB or ARNI, mineralocorticoid receptor antagonist, and the SGLT2 inhibitors. Then we also have the devices, and we know that decongestion will improve the symptoms but not mortality. So this now the class 1A indications of ACE inhibitor, beta blocker, mineralocorticoid and SGLT2 inhibitors. ARNI I will discuss in the subsequent slides. So what are the 3 aspects of the guideline directed therapy in heart failure? First of all, they should receive, the patients with reduced ejection fraction should receive all the 4 pillars. That is ACE, ARB, ARNI plus beta blocker plus mineralocorticoid plus SGLT2 receptor antagonist. So they should receive it at the target doses or at the maximum tolerated doses. I will discuss it in the next subsequent slide. And then recently Dr. Mahesh also has described the time to initiation and optimization of dosing. Usually it is very slow. It takes up to 6 months to 1 year. But now there is data, and there is data to show that if you start it early, even at a small dose, it makes significant benefit. So this is the data showing the data from the CHAMP registry. You can see that at baseline, 11 to 25% of the patients only received the target doses, and even at 1 year, it is not very different. So reaching the target doses is very, very dismal in heart failure patients, even in the Western world. So how does the benefit? You can see that this is the data comparing the benefit of patients who had received the target doses. Those received 50 to 99% of the target doses and less than 50%. You can see that even if the patients receive 50 to 99% of the target doses, they achieved almost the same benefit as the patient received the target doses. We know that many of the Indian patients, because of the low blood pressure, renal issues, we are not able to titrate the drugs to the target doses. So this is very, very important. Even if you are not able to reach the target doses, reaching at least 50% will benefit the patient significantly. So which is the best time to initiate therapy? That is very, very important. Hospitalization is the best time, because if you can start all the 4 drugs in the initial hospitalization itself, it is more likely that the patient will be taking the drugs continuously, and the chance of adhering to the therapy is much more. So this is shifting the paradigm of the guideline directed therapy. You can see that the patient on admission day or just after the blood pressure is stabilized, you can start on RAS inhibitors or ARNI. Beta blocker can be started next. Then when the patient is approaching euvolemia, you can start on beta blocker. Then you can start on mineralocorticoid receptor. And when you are shifting to the oral, you can start on SGLT2 inhibitors. So, which is preferred, the ACE inhibitor or ARNI? That is the question. The pioneer study and also the transition study has shown that ARNI initiation is better than ACE inhibition. Even though 15% of the patients can develop symptomatic hypotension, it is almost similar with ACE inhibitor therapy. So it can be started in patients with de novo, or the Canadian recommendation states, you can start it in a de novo patient as ARNI as the first line therapy, or those patients who was on an ACE inhibitor getting readmitted, you can change over to ARNI. So ARNI can be has a first line therapy. So this is there in the ACCHA guidelines also, where they prefer ARNI compared to ACE inhibitors. So compared to each of the therapies, we know that ARNI therapy, how to start and all, I am not going to discuss that. So you should make sure that you should try to double the dose at least in 2 weeks intervals, recheck the blood chemistry at around 2 weeks, and asymptomatic low blood pressure. We see many of the patients having a BP of 90, 86, etc. I think that does not require any change in therapy. ACE inhibitor therapy, always you know the drugs and the doses, I need not tell that. Try to reach 50 to 99% of the target doses, and there can be some rise of creatinine. 30 to 50% rise in creatinine is possible. If it is less than 3, need not bother much. And similarly potassium also. Whenever you uptitrate the drugs, recheck the renal function in 2 weeks. That should be done. ARBs, they are used when ACE inhibitor or ARNI is contraindicated. And beta blocker therapy starts low, goes low. But you have to switch to one of these 4 beta blockers if the patient is on another beta blocker. And also, please start these patients on who has diabetes and COPD on beta blocker, because the benefit they derive is similar to the other patients. Mineralocorticoid receptor antagonist, there is nothing much to choose between eplerenone and spironolactone. The eplerenone has less the gynecological side effects, but eplerenone is significantly costlier than spironolactone. Now coming to the 4th pillar, which is the newer addition to heart failure with reduced ejection fraction therapy, and empagliflozin or dapagliflozin 10 mg daily. Contraindication is EGFR less than 20, and also you should be bothered about the non-hyperglycemic ketoacidosis and also recurrent genitourinary infections. So I think this is the conventional sequencing versus the proposed new sequencing. I am not going to the details because I think Rajesh will be discussing subsequently about that. So planning discharge, that is very, very important. I think my previous speaker also has highlighted about that. So why planning discharge is very, very important? Because residual congestion. Because when we discharge many of our patients, they have residual congestion, and because we are discharging them with residual congestion, they are getting readmitted. 30% of the readmissions are due to heart failure exacerbation itself, and mostly it is due to the residual congestion. So what should be at least the clinical findings of a normal JVP, no edema, no lung crepitations, or no intravenous diuretic or inotropic agent for at least 24 hours, systolic BP more than 90, heart rate less than 80 or 100 in atrial fibrillation. All these clinical criteria, if you can follow, you can identify the patient with residual congestion and keep him for 1 or 2 days more and discharge him, then it will be better. The first review, that is very, very important. First review is very important because it is said that if you discharge a patient within less than 7 days, that is review the patient within 7 days, that is the best time, because most of the patients get readmitted within 7 days of discharge. Even you can ask the patient to visit a local physician and get evaluated. So ladies and gentlemen, to conclude, early initiation of all fantastic 4. This adds life. At least it is said that adding ARNI and SGLT2 inhibitors will add 5.6 years to a patient with heart failure with reduced ejection fraction. The first follow-up should be at 1 week or at least within 10 days, and titrate to the maximum tolerated dose in 3 months' time. And the other therapies I need not discuss. Thank you so much for your patient listening.